Good morning. I'd like to thank you all for being here because I believe that this is an important chance to be here and share different visions from different parts of the world. So I'd like to thank Dr. Munir for this because I have never been to the region and it's my first time in Riyadh. So I'm starting and trying to get familiar with the system here and what's going on in the region. So I have a bunch of experience in WHO Euro for more than 20 years, and I have been working with them. And since the Turkey is in the Euro region, I've been involved in the vaccination issues in the region. But the new changes in the region made us to be more to have more interest in the region because we are now sharing the agents. And we will be sharing the agents more and more each and every day. And this needs a good collaboration. And that's why I'm very happy to be here. And thank you, Dr. Miner, and all the organization committee and all the faculty for this. Now, I would just like to give a brief overview of the NIP in Turkey and just a background info, the vaccination schedules and the tracking system that we use in Turkey. And I just want to start with a background info about Turkey. Where is it? You know, I think it's between Europe and Asia, like a bridge. And we have a population of 81 million, but we also have 3.5 million registered refugees, and I think we have some unregistered ones too. And the area is, you see, 780 kilometers squares, and we have a very diverse geographic and socio-economical status. And we have different regions, and our birth cohort is approximately 1,300,000, and on top of that, you should add the refugees. And 75% live in urban settlements, and we have rather low infant mortality, under 5 mortality rates. Now, this is the vaccination schedule in Turkey. Of course, the vaccination history dates very long back, even the mid-century in the Anatolia. It's not been very new. And 1960s, we have started the immunization, and we have now 13 antigens administered to our children. Now, you see, we have hepatitis B, BCG, and diphtheria, acellular pertussis, tetanus, IPV, and HIV. It's pentavalent. And conjugated pneumococcal vaccine, MMR, OPV, DAPT, IPV, TD, hepatitis A, and varicella. The hepatitis A and varicella has been added in 2013. And now you can easily see that we don't have HPV, rotavirus, and meningococcal virus, which we see in the Saudi Arabian schedule. Now, the question was, why are we having OPV and IPV at the same time? This is also the same for Turkey. You see, we have both OPV and IPV because the OPV has its own advantages when there are still cases in the region. And if there's a risk of importation, WHO recommends that you should do both at the same time and twice at least, and because this has an extra advantages on gut immunization, and the population around also gets the secondary gain from that. So as well as we have wild or vaccine-derived polioviruses, we should go on for a while, it seems so. And WHO also recommends that. But there is a risk of turning the vaccine-derived polio strains into wild ones. So there also we are in favor of getting rid of OPV as soon as possible, but not today because it will need some time. And we have 13 antigens. They are also, may I have, do you want me to read which dose is given when, or can you see it clearly? Is there a problem with that? I don't think so. Okay. So we have MMR at the end of 12th and first grade, 12th month and first grade. It is a main difference between Saudi Arabia. If it is earlier than 12 months, you know, they are competing with the maternal antibodies. So you have 6 months, 9 months, as far as I remember, 6, 12, and 18. It's really different from ours, and the WHO recommendation is only 2 doses and 2 doses. And if it is around the end of the childhood, it's better if you give the second dose. Now, as I have mentioned, we have 13 antigens in the childhood vaccination schedules, and the vaccine is offered in all family physician centers linked to the Ministry of Health. And on top of that, we are providing vaccines to hospital clinics and private polyclinics or private clinic settings. And the only prerequisite that we want them to report us. If they report back and give the names and ages of the children that they have vaccinated, the vaccines are offered for free for the private sector. And also we have some adult vaccines for specific age groups and risk groups, and they are reimbursed. They are not free, but they are prescribed and then paid back to the individuals. Now, this is the vaccination coverage rates. I know that all of these are not here, all of the vaccines are not here, but for sample, you see that it's rather high, between 96 to 98%. And we have been registering the newborns, so we don't have difficulty if the newborn is registered. But the problem may be that you need to find the gaps, and you need to find if somewhere there are unregistered population. So you have to be very careful if you are reporting high vaccination coverage rates. I'm not saying that it's not true, but just keep in mind that there are refugees, so you should be well performing and strictly following what you're doing. Now, the main achievement in the region, the European region, is the eradication of poliovirus, and we have eradicated polio in 2002, and so we are still going on OPV, IPV, and all AFB surveillance and whatever needed for polio control, because it's really a risky region, and Turkey is just like a bridge. People are moving throughout Turkey, so we're just trying to keep the promise and really doing good in surveillance and vaccination policy. With our VPD, vaccine preventable disease control programs, you see polio eradication program, measles and rubella elimination and prevention of CRS program, tetanus elimination program. We have already eliminated it, but we're trying to keep the elimination status. Hepatitis B control and other control programs like diphtheria, pertussis, varicella, hepatitis A. And the latest is the invasive pneumococcal disease. We have started the pneumococcal vaccination in 2008, but we still didn't have enough functional surveillance for it. But these days, we are working for the last years, we're working on invasive pneumococcal disease surveillance so that we will be able to see if the vaccination schedule we are using for children is really working good in invasive pneumococcal disease. What about adult vaccination? Adult vaccination, in fact, is not settled as the childhood vaccination in many of the countries in the region. And we have started an initiative, I think approximately 9 years ago, and we have just recommended the adult immunization, and we have prepared a guideline, and you see many of these institutions here are recommending adult immunization. But now I will talk about something else that WHO is trying to implement for the last 10 years, that this is LifeCourse Approach to immunization. Because if you divide immunization into adulthood and childhood, it gives an idea or is a vision that there are 2 groups that you have to vaccinate and they are separate, but they are not. Today we know that if you vaccinate the children, for example, for pneumococcal vaccines, you got a gain in the elderly group. So, or when you finish all vaccination in the childhood, in the adolescency, the protection that you have obtained by the vaccines is tapering down, like in pertussis. So you have to look to the individual and adopt a LifeCourse approach immunization. And when you face a patient or an individual, we have to think which vaccine he or she is available for. So this vision is trying to be implemented by WHO into the country's immunization programs, and this is what we are trying to do in Turkey also, a LifeCourse approach to immunization, although we have recommendations for adult vaccination. These are the recommendations in the adult immunization guideline. When I turn it, you can't hear me, so just like this. You see the TD or Tdap, one of them should be Tdap, is recommended for every 10 years for each and every individual, and influenza for every individual for 1 dose for each year, and pneumococcal vaccines, hepatitis B, A is routine vaccinations that is recommended for all adults in the country. Of course, this is not a settled down program, as I have mentioned, and of course, Ministry of Health supports this initiative and reimburses some vaccines, but they are not endorsing the whole program yet. And this is the schedule for the risk groups. Sorry, this is in Turkish, but the risk, you can understand, I think, the disease names, and you see we have also recommendations for the risk groups. So this is another portion of the immunization program, I think as important as the vaccination schedule, surveillance, because if you don't do surveillance, you can't understand if you're performing well enough with your immunization program. And if there is a change in the dosing or timing or whatever, or kind of vaccine that you're using. So you should be having data about what's going on in the country in terms of vaccine preventable diseases. So we had a surveillance system. We revised it updated in 2005 and revised in 2011, and we have now 73 notifiable diseases, and they are notified under 4 groups. Most of the vaccine preventable diseases in group A, and they are to be reported from each and every physician in the country wherever they are, and health center. And of course, if you are linked to WHO, which is the WHO EMRO in this region, you have to have internal and external reporting requirements because they are not always fitting each other. The internal, this means in Turkey, when we are doing the surveillance, we use case definitions, case classifications, and we have designed the required data elements, surveillance schemes, and the different surveillance types defined for different diseases. For example, for AFP we have, or measles, we have active surveillance. We visit the sites and we see if all the patients are reported and notified. But for others, like diphtheria, pertussis, we have passive immunization system, surveillance system. They are defined, they have their own forms, and each month they are, or sometimes weekly, reported passively. And we also have sentinel surveillance for Haemophilus influenza type B and IPD. And in the coming sessions, we will be discussing how new vaccines can be introduced and how the effect on the general epidemiology of the vaccine preventable diseases they have. So we need to have surveillance in place, and I personally believe that not only the vaccines and the vaccination schedules, but also the surveillance system should also be discussed in such meetings. And external, of course, if you're reporting to the other systems like ÖVAC, or other EU networks, then we have other case definitions, classifications, and laboratory tests. Now we have different contact points assigned for European working groups for Legionella, for example, enteric infections, or the influenza. And we are the collaborators of diphtheria network, International Network of National Public Health Institutions, tuberculosis. So we're not alone on earth. So we have links with the other countries and other networks. And this is something, as far as I know, unique for Turkey. We are using a vaccine tracking system, and we all have barcodes on the vaccine vials. And we don't have a local production of vaccines, and we purchase them from other countries or other manufacturers, depending on the recommendations of NITAG. Of course, the NITAG takes into account the epidemiology of the disease in the country, available vaccines, and what's going on in the other regions as well. And they recommend to the Ministry of Health, and the last decision is, as always, Ministry of Health's decision. And since we have no local production, licensing and selection of the vaccines is also recommended by this group. And purchased vaccines are tested in national labs, and all the vaccines and their cold chain has been tracked by vaccine tracking system. And when the barcode is read by the special system in the doctor's clinics, you can easily see that if the expiry date is passed or what's the lot number, all are recorded automatically, and the depot can be also tracked by this if you have a vaccine shortage or not, what's the need of that individual physician, etc. So cold chain rules are applied as in the other regions, and they are all tracked. So this is what, you had 10 minutes, so I just summarized the general system. If you have more questions, I can easily answer.